So I'm going to talk about renal anatomy and physiology. Where's the click-through? Okay, just a little outline. We'll go through renal gross anatomy and variations in normal anatomy, microscopic anatomy and function of the kidney, everybody's favorite topic, and then a little bit about renal endocrine function and the pathophysiology of renal artery stenosis. So, as many of you know, the gross anatomy of the kidney, there's two of them most of the time. And they're about 11 to 12 centimeters in length, actually, which is an important thing to know because you'll have many scans, incidentally, where renal artery disease is picked up because of discrepancy in size of the kidneys. And, of course, the hilum of the kidney is really, kind of where things are at, and it involves the renal artery, the vein, the nerve plexus, and the beginning of the collecting system in the ureter. In terms of the size of the kidney, I think it's really it's important to know the size and to know what some of the signs you see are that may indicate renal ischemia. And the loss of renal parenchyma, usually described in imaging studies as a loss of cortical thickness. That's really the key thing you'll see. Can indicate that there's not only potentially ischemia, but there's some loss of renal function because of obstruction, infection, reflux nephropathy, or even some chronic intrinsic renal diseases. You often get imaging studies, particularly CT scans, where you see discrepancy in size of the kidneys, which is clues to the pathophysiology of what might be going on. And of course, then you can do a variety of nuclear scans, LASIK scans, captopril scans. There are a whole variety of nuclear imaging-based scans where you can determine the relative function of each kidney. So the kidneys really lie incredibly posteriorly, and you see here, you hear how the posterior view explains why kidney disease presents as costovertebral angle tenderness, really the only point of this slide. So in terms of the gross anatomy of the kidney, this is looking from the top in a cross section, so the liver there is on the right kidney, and I think the important thing here is to actually see those planes, see those retroperitoneal planes, and there are two retroperitoneal planes. One's anterior to the kidney, and one's posterior to the kidney. And that has implications for how you, which way you mobilize the kidney for certain disease processes, particularly paravisceral and thoracoabdominal aortic operations. So it's important to visualize those planes. One of the anatomic variants we see is a horseshoe kidney, where there is some either isthmus, which is usually some fibrous tissue and therefore actually not functional parenchyma, or actually functioning parenchyma, which is between the two kidneys, and the kidney is one continuous organ. And actually, the blood supply of the horseshoe kidneys is really quite important. It can be relatively normal, meaning you can have fairly normal position of the renal arteries feeding that kidney. But more commonly, there's a whole variety of branches off of the distal aorta, sometimes even off the iliac arteries, which actually perfuse part of the kidneys. And then you really need to take that into account when you are approaching, usually for abdominal aortic operations. So that needs to be considered in your options for either reimplanting some of those vessels, perhaps a retroperitoneal approach where you avoid some of those vessels. So there's a lot of implications to horseshoe kidney and AAA repair, or even occlusive disease of the aorta. Another common abnormality is the ectopic kidney, usually found in the pelvis. You get a clue here from this. You can see on this urogram here that the collecting system to the bladder is down off of the iliac arteries on the right side. So, arterial supply of the kidney. Kidneys get a lot of blood flow, about 25% of the cardiac output per minute. The kidneys, as they come off of the aorta, branch into the anterior and posterior branches, then into the segmental branches, then interlobar branches, then the afferent arterioles to the glomerulus, and then the efferent arterioles, which, if you recall your physiology, we'll get into this when we'll talk a little bit about renal artery stenosis. It's that vasoconstriction at the efferent arteriole that kind of keeps a perfusion pressure of the glomerulus up in the settings when the perfusion pressure in the afferent arteriole is lacking. And that's an important thing to remember with the management of renal artery stenosis. All the kidneys are end arteries, and so any embolus or disease or obstruction of these end arteries will lead to ischemia of that segment. The question will be, are enough segments involved to impact renal function? So it'll be irrecoverable for that particular segment that's fed. A schematic of what I just described. So you'll see the variations in renal artery anatomy are extremely common. Double renal arteries, accessory renal arteries, duplication of arteries, exceedingly common on both sides, and really needs to be considered, particularly for aneurysm disease, and also for occlusive disease in both your endovascular and your open management. Venous supply of the kidney, blood enters into the interlobar veins, arcuate veins, then comes into the main renal veins. I think the key thing to remember here for surgical anatomy is, in general, the left renal vein is just a key landmark. It's a long vein. The right renal vein is exceedingly short. It drains from the kidney into the right lateral aspect of the inferior vena cava. But the left renal vein is really a key landmark, and the management of the left renal vein, or the branches of the left renal vein in surgical exposures, are extremely important. 95% of the population has a normally placed left renal vein, meaning crosses anterior to the aorta to then go into the cava. About 4 to 5% of the time, there is either a circumaortic system or there is a retroaortic renal vein. This is a sagittal view, so if the patient's on the side, you're looking at the renal vein like this, it just kind of, it describes the branches of the renal vein that need to be managed during aortic exposure or renal artery exposure. So the left renal vein is really the doorway to both the pararenal aorta as well as the origins of the left and right renal arteries. And the key veins, see if it's not quite as big as I'd like here. They see here coming up to the, on the underside of the left renal vein is a gonadal vein. On the top side is an adrenal vein. And then posterior to the kidney, and you can't really, posterior to the renal vein, you can't really see it on this schematic, is a lumbar vein, or a lumborenal vein, which drains into the backside of the left renal vein. So the management there is really key. If you're going to mobilize the renal vein, which you often need to do for either renal artery occlusive disease or aortic operations, you need to ligate all 3 of those branches. Then the renal vein can be brought low and it can be brought high. The other where that also comes into play is the issue of division of the renal vein. So many people describe routine almost division of the left renal vein in order to expose the pararenal aorta. Now that can be done, and that's sort of debated, but if that's done, those branches have to be kept open, so because they become the outflow from the kidney. So that's really a key surgical point of the anatomy. You can ligate the renal vein, or you can ligate the branches. You can't ligate both. So here's a picture of the retroaortic renal vein. About 4 to 5% of patients, a little blowing up there in the window. And obviously, if you have the luxury of knowing that, which we usually do, even in emergent situations these days, it's one of the first things you need to look for. Obviously, to get into a retroaortic renal vein when you're clamping either above or below the renal arteries for aortic reconstruction, that's a potentially hazardous area and difficult to deal with. So you need to know as much as you can. You need to know that going in, look for that going in, and when you get into the operation, you need to make sure that the left renal vein is where it should be, anterior to the aorta. Circumaortic renal vein is another. Less than 1% of the population has a bifid system that surrounds the aorta. So here's the real interesting stuff, the microscopic anatomy of the kidney. Really, there's 4 components of the filtering system of the kidney, and I'm going to talk about 2 functions of the kidney. It obviously has an exocrine function and an endocrine function. So the exocrine function is removal of waste, salt-water balance, acid-base balance, and the key unit that does that is the nephron, where adults have about 1 million nephrons. And here's just a schematic of each of the each nephron, which then drains into through the papilla there at the bottom into the collecting system and empties and drains urine from the kidney. So the key, in the glomerulus, the filter function is really due to its barrier, both in terms of a mechanical barrier and a charge-based barrier, which basically keeps things that should not be migrating through the barrier, mostly proteins, from migrating through that barrier and getting into the urine, causing albuminuria, hypoproteinemia, and therefore edema. So one important thing that maybe you see on some initial, you won't really see this on vascular boards, but maybe some in-services and things, is GFR versus creatinine clearance. GFR is a calculated value. That estimates creatinine clearance. Creatinine clearance is a measured value. And that's sort of the take-home point here. In order to measure your creatinine clearance, you actually have to measure the creatinine in the urine, measure the amount of urine, and put that over your plasma creatinine. What we do instead of doing that with people, we draw blood and we calculate a GFR. So that GFR estimates the true creatinine clearance. And you can see here that there's the formula for GFR, and you'll see that a very big factor in the numerator of that formula is 140 minus age. So that actually makes the calculation of the GFR highly dependent upon age. So a 20-year-old person will have twice the creatinine clearance of an 80-year-old person for the same level of serum creatinine. Something to think about when you go into angiography in people with our older patients and they have borderline renal function. So in terms of chronic kidney disease, normal or adequate is considered 60 milliliters per minute per 1.73 meters squared. Normal kidney function is actually above 90, no proteinuria. Stage 1 is above 90, but they have some evidence of kidney disease. Stage 2 is GFR between 60 and 90 with evidence of kidney disease, and then 3, 4, and 5 are increasingly diminished GFRs from that point on. Stage 5, less than 15 mLs per minute per 1.73 meters squared. Kidneys also have an endocrine function. That main hormone they secrete that's important is renin. We'll talk a little bit about that now. As you know, the renin-angiotensin axis is really responsible for maintaining volume and blood pressure and contributes to that. Interesting history here in this area. Actually, as early as 1836, Richard Bright, for whom Bright disease is named, noted an association between calcified arteries and granular shrunken kidneys. And then Goldblatt in 34 did all of the classic experiments with constriction of the renal arteries in dogs, which showed that hypertension showed the relationship between hypertension and renal ischemic disease. So to skip ahead, I'll give you a little bit of the normal physiology to think about when you're talking about renal artery stenosis. So blood pressure drops, activation, that glomerulus is seeing less blood. Renin is therefore produced. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1 gets converted to angiotensin 2, and then that has the effect of vasoconstricting the efferent arterial to increase the perfusion pressure of that glomerulus. ACE inhibitors therefore work there. They work by preventing the conversion of angiotensin 1 to 2. And so what you see here in renal artery stenosis is the kidney seeing less blood. The kidney wants to increase the perfusion of the glomerulus by angiotensin 2 impact on the efferent arterial. And then if someone's on an ACE inhibitor, or even more so with an angiotensin receptor blocker, that's when their kidney function will go down. So that'll often be a clue of ischemic nephropathy. And then other folks will talk about how to manage this problem of atherosclerotic renal artery disease or renal artery disease that is secondary to fibromuscular dysplasia. Thank you very much.